technical hitch. Thank you, Bishnujai, for covering me. Today I'm going to talk about a very common condition which we all know, and usually during our practice, I think most of us has made every shoulder problem as this diagnosis, because as we grow, well, now we understand that this is the condition which is very commonly misdiagnosed and this is the term, this is the diagnosis which is very commonly abused by us orthopedic surgeons. So I think let's dive into this context, let's dive into this frozen shoulder world and know what it is. So Codman in 1934, he described this particular condition as difficult to define, difficult to treat, and difficult to explain. See, that was 1931, this was 2025, and this thing still holds true. Still today, it is difficult to define, difficult to treat, and difficult to explain. Many people had described this condition variously. Like in 1872, Duplay has mentioned it as periarthritis. It is some arthritic condition around the shoulder, just like other arthritis. In 1934, Codman described it's a sort of frozen thing. The capsule is all frozen, that's why it is called frozen shoulder. In 1945, Nebuchadnezzar came with the term adhesive capsulitis. He considered it is an inflammatory condition, that's why it is a capsulitis, and there is adhesion, that's why it is adhesive capsulitis. But nobody was right. 1992 ASES consensus, they came very close to what actually is the pathophysiology. They told it a condition of uncertain etiology characterized by significant restriction of both active and passive motion that occurs in absence of known intrinsic shoulder condition. This is very important. Known intrinsic shoulder condition. That means it has to be idiopathic. So as we all know, there are many medical myths in our medical practice. For us, every shortness of breath is COPD, every abdominal pain is APD. Similarly, every shoulder pain is frozen shoulder. That is not true. Just as every abdominal pain is not APD, or every shortness of breath is not COPD. These are the various causes within the shoulder joint which may cause the shoulder pain. And mind you, shoulder is one of the most common joint where you can have the radiation, even the MI, even the diaphragmatic pain, even the gallbladder pain, anything can radiate to shoulder. Cervical pain, C-spine pain, they can radiate to shoulder. You have to rule out all of these before diagnosing a particular condition of shoulder joint pain. Rotator cuff tendinosis, younger age is the most common cause of shoulder pain. Rotator cuff tear in older age, instability in younger age, the arthritis in older age. These are the commonest cause. And in female, when they have sudden pain in shoulder joint, usually they are calcific tendinitis. And frozen shoulder constitute very, very little part of this whole shoulder pain scenario. What we all define, all shoulder pain are frozen shoulder unless proven otherwise. This is not true. Actually, many of these shoulder pains are because of rotator cuff problem, and rotator cuff problem, it should not be tear. Rotator cuff may be weak, because of which the shoulder biomechanics has gone wrong, and because of which the shoulder is painful. If they could do good physiotherapy, good rehab, get the function right, get the force couple right, then shoulder pain will go away. So frozen shoulder constitute only about 2 to 4% of those shoulder pain. So what it should be, frozen shoulder is cause of shoulder pain when all known causes has been excluded. But what we do, we jump into the frozen shoulder immediately. What is the classical teaching in frozen shoulder is self-limiting. Frozen shoulder has some stages, 4 stages, and it has some time period like 3 months, 4 months, and it follows the stages religiously. It does not. These particular stages and this concept of self-limiting was given by Codman in 1934. That was not any scientific research paper, that was just all the clinical judgment of Codman, and he published a paper and everybody started following me because he was a very well-known physician at that time, surgeon at that time. So till today we are following that particular concept, and many of recent literature has shown the results against this particular belief. Like this, painful period may range from 10 to 36 weeks, stiff period may range from 4 to 12 weeks, recovery period may range from 5 to 26. This article in JSES said that 90% resolved after 3 years. What we all know from our classical teaching, at 1 year, frozen shoulder will be gone, but it does not. 10% are still affected after 3 years. 50% had pain and stiffness even after 7 years. Long waiting, go ahead. Long waiting. Problem with long waiting is body does not wait for frozen shoulder to heal on itself, So what happens is, in those long waiting time, the shoulder is not moving externally, shoulder is not moving above. So when it is not moving, those muscles are not acting, because of which those muscles will be wasted. And once you wait for 3 years, 2 years, 1 year, all those muscles will be wasted and one function is back. It is very difficult to get the 100% function back. And another issue is, we believe these all freezing phase, frozen phase, thawing phase, the frozen shoulder will follow these phases religiously. It does not. How come shoulder will know that it has already become 3 months and now I have to change from freezing to frozen phase? It does not. One phase may last longer. These 3 phases do occur. These 3 phases are there in every frozen shoulder, but it is not like after 3 months the phases are changed. It does not follow the stages religiously. That also we should know, I think. And there are multiple etiologies. The frozen shoulder, classical frozen shoulder, which we all know is idiopathic, and there are risk factors for this particular frozen shoulder. The frozen shoulder risk factors are diabetes. Diabetes are very, very common patients to have frozen shoulder, and they have not good results. Thyroid disorder, CVA patient, CAD patients, autoimmune disease, Dupuytren's contracture disease, female patient age over 40. These all are risk factors for frozen shoulder. But mind you, frozen shoulder is always idiopathic. So why this frozen shoulder actually happened? To know this, we have to know the etiopathogenesis. So like all joints, like in hip joint, knee joint, elbow joint, there is always one group of muscle is always stronger than other group of muscle. For example, in hip, if we put that patient in supine position, it tends to go into flexion, abduction and external rotation. Knee tends to go into flexion, elbow tends to go into flexion. So similarly, shoulder always tends to go into internal rotation. Why? Because there are 5 internal rotators: subscap, pectoralis major, lat dorsi, pec minor, and one I forgot. 5 frozen internal rotators, which are very strong muscles, and only 2 external rotators, that is infraspinatus and teres minor. So always internal rotators are overhand, and they tend to get that shoulder into internal rotation always. So weak ISP means weak infraspinatus, strong internal rotators. By doing so, what happens? Head of humerus and coracoid process, they come into contact, and there is some extramarital affair between subscap and long head of biceps, because of which there will be adhesion between those two. And long head of biceps is the pain generator in shoulder, number 1 pain generator. When this long head of biceps is rubbed with coracoid process and it is stuck, then there will be the problem. The long head of biceps is stuck, so internal rotation cannot be done. There will be zero internal rotation, zero external rotation, and zero external rotation means this is a problem. And when there is no external rotation, for shoulder to abduct fully like this 180 degree, you should do external rotation. If we continue doing abduction up to this 90 degree only, you will be able to abduct. To abduct your shoulder more than that, you have to external rotate. Always you have to external rotate. So if there is no external rotation, no abduction. So this is the cascade of frozen shoulder. So what happens? In shoulder, there is always a force couple. There is horizontal force couple, vertical force couple. Here we are concerned with horizontal force couple. Anterior there is subscap, upper subscap, lower subscap. Posterior there is infraspinatus and teres minor. These are balanced. That's why center of head and center of glenoid, they are congruent. They lie into same plane. That's why the head can be functioned. Head can be moved with the help of deltoid and other rotator cuff muscle. But what happens if the infraspinatus become weakened? and the internal rotators, that is subscap, becomes very strong. They tend to pull the head, internal rotate, they tend to do internal rotation and pull the head anteriorly, because of which the center of rotation of head and glenoid is disturbed. And then what happens, that there is coracoid, this thing is coracoid, there is adhesion between coracoid and the long head of biceps, and the conjoint tendon is there. All these 3 or 4 structures become stuck, and because of which shoulder no longer goes into external rotation. That is the main pathophysiology of frozen shoulder. So the main hallmark of frozen shoulder in clinical examination is restricted range of motion, both active and passive. Restricted range of motion is the main important thing. Patient early stage may have good abduction, that is axial movement like forward flexion, abduction, they may be preserved, but rotations are lost. External rotation is primarily lost, internal rotation is also lost. If patient presenting with rotational loss like 0 degree, 20 degree only external rotation compared to 70 degree external rotation on other side, that is frozen shoulder until proven otherwise. So that is very important, and patient should have normal X-ray. There are only 2 conditions that can mimic frozen shoulder, that is locked posterior dislocation of shoulder and the shoulder joint which is arthritic. Because of arthritis, the shoulder no more behaves like ball and socket joint, it now behaves like a hinge joint. That's why there is good axial movement and rotation is gone. There are the only 2 conditions that can mimic frozen shoulder. So normal X-ray, the strength should be intact. These are the clinical hallmark of frozen shoulder. So treat the cause, that is the internal rotators have been strong enough, there is adhesion, you have to break those adhesions, so stretching becomes the key. The anterior capsule, which is very strong, which is very adhered, that has to be stretched. External rotation strengthening has to be done. Internal rotator strengthening has also to be done. These are various methods which you do. And mind you, if your patient have good passive range of motion and active range of, even no active range of motion, if you can move that shoulder externally to 50 degree or 60 degree, that is not frozen shoulder. So injections, we give injection to patient as a treatment modality, but it is not. Actually, injection is given so that patient can comply with the physiotherapy. It is the physiotherapy, it is stretching which cures this frozen shoulder condition. This helps to jump that one stage to another, the stage of is skipped. And steroid injection is given only to help the physiotherapy compliance. Manipulation, I don't like it, but many of our senior surgeons do it, and they have very good result. I'm not against it, but I think this is very crude and very, there are many complications that has been described with manipulation, because this is still, though it is under anesthesia, the shoulder starts moving because of tearing apart of structures, and what you are tearing, you never know. You may be tearing muscles, you may be tearing cuff, you may be tearing labrum, you may be even fracturing the bone. So I think this is very crude and one should not practice in today's era. So those cases, only in I think 3 to 5% of cases, in spite of good physiotherapy protocol, injection, everything, they are not improved. Patient cannot sleep for months. They cannot do activities of daily living. In those cases where there is external rotation is still 0, then arthroscopic release is the method. Still, I want to highlight conservative treatment is first treatment. Only indolent cases will require surgery. This is a few cases where we have done the arthroscopic release. This patient young, very painful, not slept for 3 months, came with lots of agony, had been under physiotherapy for so long. He had no abduction, no external rotation. Rotation is not there. Almost see other side there is good rotation. This side there is no rotation. So what we did arthroscopic release. Even entering in the joint is very difficult in this frozen shoulder, and once you enter, it is all red because it is all inflamed. This is rotator interval in between the long head of biceps and subscap, and you have to release this rotator interval all. You have to make the coracoid process naked. Everything has to be released except the conjoint tendon. The coracoacromial ligament has to be released. The CH ligament, which is the main culprit, that has to be released. and the anterior capsule, posterior capsule, whole 360-degree release has to be done. That is the coracoid process which I am releasing, and this is the cutting. The capsule is being released from anterior, whole of the anterior part. This is whole 360-degree capsule is being released. I use the punch forceps, and this is how it is. And slowly you will feel the shoulder is getting filled up with more fluid, and there will be more movement, and patient will be the movement will be more. You will feel more movement. So that is how we do whole 360-degree release. This is anterior release. We go posteriorly, and even in posterior side we do the same procedure. This is after about a week of surgery. I came for follow-up, and he's have almost attained 100% of movement, whole rotation. Pain has gone down, everything has gone down. So this is how this. Sometimes in long cases like patient complaints, patient who has complained about 4 months, 6 months, and they have some, if they have coracoid tenderness, they have some numbness, then what we do, we add this surgery along with the knob releases, because suprascapular knob is one of the 90%, 95% of shoulder sensory supply is given by suprascapular knob. So what we do is we go around the coracoid process, we find out the transverse scapular ligament, and underneath the transverse scapular ligament there is a suprascapular knob, above which is the suprascapular artery and vein. That is CC ligament, base of coracoid is there, there is the knob. So if you trace it, that is the CC ligament, we should not cut it. Go below that, it's just like this, goes just like this, the ligament, and then there is the ligament. So that is the ligament above, and knob is just beneath. So that is above is the ligament, and that is knob. And by releasing only, the patient will be having, this is just like carpal tunnel of shoulder, just like carpal tunnel release, we do release of this particular ligament, and knob is all of a sudden it's free, and patient is pain free. Sometimes when we go next level, and we do pec minor release. This is coracoid process, pec minor has been released, and that is brachial plexus. And sometimes the brachial plexus are also, because what we have known is the frozen shoulder is not only an intra-articular disease, it is even an extra-articular disease. If you go to subacromial space, it is as inflamed as the intra-articular part. So it is even a subacromial extra-articular disease process. So pec minor, that becomes scarred, because of which there will be scarring of the brachial plexus, around brachial plexus. So we do sometimes do arthroscopic brachial plexus release, but these are very rare cases where their patient has severe pain, out of proportion pain. Otherwise only the rotor interval release and the 360 release of capsule suffices. So take home message, I think frozen shoulder is still an enigma. Nobody knows, everybody understands on their own way. That it is my understanding. It is certainly not an inflammatory condition, but it starts with altered biomechanics. If you can correct altered biomechanics at early time, the frozen shoulder can be prevented. Both intra and extra-articular disease, knob intravertebral may be the part of disease in very long disease process, and surgically beneficial, surgery may be beneficial in some percentage of cases where it is not improving with physiotherapy. Thank you so much.